There we go. Alrighty. So in terms of what we'll cover today, I'm going to give you a little bit of genetic basics and orientation to understand exactly what we're going to be discussing. We're going to work on understanding copy number variants, also known as CNVs. And I'm going to teach you a little bit about 4 specific syndromes: 22q11 deletion syndrome, Williams syndrome, 16p11.2 deletion syndrome, and 16p11.2 duplication syndrome. And lastly, I'll finish up with some resources and support. So to kind of take a real step back, I like to think of genes like recipes because I think that's an easy way to understand them. You can think that every gene is a recipe, and then it teaches us how to make a different dish. So, they teach us how to make different parts of the body, but it's kind of like a recipe for a cookie, a recipe for a piece of cake, and so on. All those recipes are arranged onto cookbooks. And you get one set of 23 cookbooks from mom, one set of 23 cookbooks from dad. And it's almost like there's 2 matching bookshelves of 23 cookbooks. Of course, the number isn't right here in this picture, but they all exist within our cells. Now, the cookbooks are called chromosomes when we talk about medical terms, and this is what they look like. Some of you guys may have come across pictures like this, whether in biology class or somewhere else in the world. And this is what our chromosomes look like, and this is how our genes are organized inside our cells. And you'll see that they're all numbered from 1 all the way through 22. And the last ones are X and Y. So women have 2 X's, males have X and Y for their chromosomes. You can see that if you look at the chromosomes in this microscopic picture, there's all these bands almost like horizontal lines, some of them light, some of them dark. And we'll talk about how those bands are used to actually help us orient within the chromosome. A quick chromosome orientation, like I discussed. You may have noticed on this previous picture, some of the chromosomes are very long and straight. Some of them seem to have a shorter section up top and a longer section on bottom. Some of them seem to have almost nothing on top and a lot of stuff on the bottom. And so that actually pertains or corresponds to different types of chromosomes. And so we have 3 different types within human cells. These are called acrocentric. You don't need to know that. And then there's different types here as well. The important thing to know is that within chromosomes, we orient ourselves to the short arm, so to speak, which is the P arm. P stands for petite, and the long arm, the Q arm. And Q doesn't stand for anything, it just comes after P. That's how it was named that way. And so whenever we talk about different deletion syndromes, duplication syndromes, when we say P or Q, that's what we're referring to. And I showed you those bands on the chromosome microscopic picture. And here's a cartoon of what a chromosome might look like. So this is chromosome number 5. Now you can see over here that there's 2 different sections to each of these chromosomes. A lot of the times in our cells, they're not duplicated this way. They just live as one single band. And so here you'll see that one single line. And this is chromosome 5. And you may have noticed that there's the cinch in the middle. And up top is a shorter section. That's the P arm. Down below is the longer section called the Q arm. And you'll see all these bands are numbered. It's a little small and hard to read, but right at the very center, we start with 1, 1, then we go out to 1, 2, 1, 3, 1, 4, 1, 5, etc. And you can see that you see 1, 3.1, 1, 3.2, and so on. So that's telling us what band of chromosome we're talking about. And it can get really detailed when you're getting into a smaller and smaller section. And so, first of all, what's a copy number variant? So a lot of people in the world are familiar with things like Down syndrome or trisomy 21, that's the medical term for it. And those folks have an entire extra copy of a chromosome or a cookbook. Now, a copy number variant is something a little bit even more microscopic than that. I'm missing one section of a chromosome, or I have an extra copy of one section of a chromosome. And so it's kind of like having missing pages from those cookbooks that we talked about, because the cookbooks represent full chromosomes. If you rip out a couple of pages, then you end up missing some small section of it. And so, like I said, missing pages from a cookbook is called a microdeletion. It looks kind of like this. And if you have extra pages in a cookbook, we call that a microduplication, and kind of like that. And so you might understand that what's happening is that you take the cookbook off the bookshelf, you're flipping through the pages, and you see, hey, some part is ripped out. That's like missing a part of your chromosome. That's like 22q11 deletion syndrome, like we'll talk about. Now, we call them copy number variants, or CNVs, because that encapsulates both the missing and the extra versions. And it's also a smaller term to say microdeletion, microduplication, kind of a mouthful. So how is a CNV, a copy number variant, diagnosed? It's diagnosed by a test called a chromosomal microarray analysis. And a lot of times you'll hear people just abbreviate that as CMA. And so that's kind of like you take all the genetic material you get from mom and all the genetic material you get from dad, you line it up so it's all aligned, you cut it up into little pieces, and then you take attendance. So what you're saying is, I expect there to be 2 of everything, because like we talked about, we get pairs of all our chromosomes. So are there any missing chunks or extra chunks? It doesn't actually read the genes or the recipes to see if there's misspellings. All it does is it looks for too much or too little. And so that's what we do with the chromosomal microarray analysis. And now let's see what it looks like when we actually look at it in the laboratory. So a little hard to read again, but I hope you can appreciate these are chromosome 1, 2, 3, and so on, all the way down to 22 and X and Y. So you can see how these blue colors, these little blue dots, all cluster around a central line. And so this is a person with a normal CMA result. And so there's nothing that's too far away from the horizontal line, nothing that's too far away in either direction. And so if you had something that was too far away in either direction, you might have a copy number variant. So this is normal. And so here's what somebody's chromosomal microarray analysis might look like if it was abnormal. And so you can't, it's not labeled here, but this is chromosome number 22. And you can see that in the section Q11.21, right, on the long arm at band 11, you'll see here all the stuff is around this line, but this one section is below the line. So that's telling us there's a deletion there. There's less material than we expect. And so this is what it looks like in the laboratory. If you or your child or somebody you know were to get a test like this, you wouldn't get something like an image like this on your report. You would just get a summary of it in words. So how many CNVs are there? Well, you can imagine we have 23 chromosomes, right? And you could have missing or extra chunks of every single chromosome you have. And so there's really an infinite number of CNVs. But the thing is, there are some CNVs that occur again and again and again in people, and we call those recurrent. And part of the reason that happens is because of some specifics of the way chromosomes are structured and the way they replicate and things like that. We don't have to get into that here, but just know that there's certain CNVs that happen again and again in people, and that's why we know them well. And those are some of the ones that we'll talk about some more today. So a quick note on CNVs, and this really applies to any type of genetic change or difference. Thinking back to the recipe for a cookie, right? If a gene is like a recipe or a genetic material is like a recipe, you can have a benign change in a recipe. You could take regular sugar and turn it into brown sugar in a cookie recipe, and it'll still work. It's a change, it's a CNV, but it doesn't cause a medical problem. You can have a variant of uncertain significance. A lot of times doctors will call that a VUS, and that's a CNV that may or may not cause a medical problem. So if you imagine that recipe for a cookie, it could be a CNV where, okay, I change the recipe where I turn sugar into honey. So it's a change, but just looking at the recipe, you can't tell how problematic that change will be. You can't tell if it'll change the cookie altogether, if it won't bake, if the texture will be wrong. You just can't tell looking at it. And you can also have what's called a pathogenic change, and that's a CNV that definitely causes a medical problem. And so it's very obvious from looking at the change that this is going to cause a problem, or we've seen it in other people who have medical issues, so we know that it all goes again and again and fits together. And so that's like if you were taking a recipe for a sweet, a cookie, and you change sugar into salt. It's really obvious just looking at the recipe that that's not going to work very well. And so that's what we call pathogenic changes. And so today we're going to focus on 4 different pathogenic CNVs, specific deletion and duplication syndromes. And so I'll talk about a few selected CNV syndromes today, like I discussed. We'll talk about 22q deletion syndrome, Williams syndrome, 16p11.2 deletion syndrome, and 16p11.2 duplication syndrome. And all these pictures are from some lovely websites online that I'll mention to you guys towards the end here. So talking about 22q11 deletion syndrome, It's also known as DeGeorge syndrome. Another name that I couldn't fit on the slide is velocardiofacial syndrome, or VCFS. So if you guys have heard about one of those, you have heard about 22q deletion syndrome. And the reason that some of these older names are applied were, DeGeorge was the name of a scientist or a physician who actually mentioned or kind of figured out the syndrome early on. And some of the other names just refer to some of the medical problems that can occur with it. So DeGeorge is actually probably the most common CNV that affects people that's disease causing. It affects at least 1 in 4,000 people. It's a deletion of 22q11.2, that band, and I'll show you on the next slide what that looks like. And it has a combination of medical features. Now, DeGeorge is quite complicated. It can cause lots and lots of different types of medical issues in different people, and it affects different people in different ways. And so this list here is definitely not comprehensive, but it's a little bit of a flavor of what you might see. So these children usually have congenital heart disease. That means a difference in the heart structure at birth. So typical folks have, 4 chambers in the heart has certain blood vessels coming off of it and things like that. Children with 22q might have differences in that structure. They have defects in their palate. So they might have a cleft palate where you can look in and you can see there's a hole in the roof of the mouth. They may have what's called a submucous cleft palate, where it's actually, you can't see it visibly, but if you took like a special microscope and you looked above the roof of the mouth, you'd see a little hole there. They may have something called velopharyngeal insufficiency, which is kind of like there's some differences in the way the throat structure is, and it causes them to have differences in their voice or their swallowing. They can have problems with their immune system. So they can have low immune, like certain white blood cells, and they might not be able to fight off infections well. They might have hearing loss. They might have problems with learning, and they might have autism spectrum disorder. Like I said, this is not a comprehensive list, but this is a small flavor of what you might see in a person who has 22q deletion syndrome. And I didn't list it here, but folks with 22q often also have unique facial features. Now, this little boy over here, me as a geneticist, I'm trained to notice all the small differences in a person's facial structure. So I'm noticing some small changes. But you can see that if you saw this little boy on the street, you wouldn't really notice anything. And that's pretty typical. Folks with 22q might look a little bit unique to a physician, but to folks who aren't physicians, who aren't trained to look at this, they might not notice anything. So when should we suspect a 22q11 deletion? So over here, I'm just showing you guys what a 22 chromosome looks like. And this is 22 is one of those chromosomes that's acrocentric, where there's a little tiny nubbin in the P arm, but the Q arm is really where most of the stuff is happening. And so down here, you'll see 22q11.2 is that particular band, and people with 22q deletion are missing that band. And so a lot of times people with 22q, especially in infancy, will have low calcium levels. They could be born with congenital heart disease. They'll have those palate defects that we talked about. They might have specific immune deficiencies. If they have developmental delay or learning problems, and if they have other differences in their body structure that people might know of as birth defects, right? So if you ever see a combination of these as a physician or even as a parent, you can say, hey, I should get my child tested for 22q. So how do we manage 22q deletion syndrome? So it's a pretty complex disorder, like I talked about. So if you have differences in your heart structure or your palate or different parts of your body, you might need surgery to correct those. We'd want to check your white blood cell counts to make sure your immune system is healthy. We want to check your calcium levels regularly to make sure that it's also staying okay. Because if your calcium gets too low, you can have other medical problems from that. We check thyroid function regularly because their thyroid hormones just might not be produced appropriately. We do kidney ultrasounds because they can have differences in the structure of their kidneys. We check their hearing because, like I said, they can have hearing loss. We have them evaluated by an ENT doctor to look and see if there's differences in the palate structure and things like that. We have them evaluated by an eye doctor because they can have differences in their eye muscles, their eye structure, and things like that. And we also make sure they have regular developmental assessments because some, not all, have developmental delay or learning disability. And so having somebody who's looking closely to make sure they're developing appropriately can be helpful because then we can get them in therapies early if they need to. There's also long-term care for 22q deletion syndrome because it's a pretty complex disorder, like I said, and it really has lifelong effects. And so once the children start to speak, you want to see if they have very nasal speech because that could be a cause, or that could be from velopharyngeal insufficiency. And if they had that, they might need surgery. We check their blood counts yearly to make sure their white blood cells are staying normal. We check their calcium quite frequently when they're infants, and we also check it before and after surgery to make sure it didn't drop during that time. We check their thyroid every single year, and I call them thyroid function tests, which sounds like it's something invasive, but it's just a blood test. We check hearing in infancy, during preschool, and during school, because if we miss that a child has hearing loss, that can of course affect their learning. So we want to make sure we're on top of that. We check them for scoliosis yearly. So most folks get checked for scoliosis when they're teenagers, but kids with 22q are at risk for it when they're younger too. So we watch that closely. And we make sure they get dental exams every 6 months, although I guess we all should be doing that. Well, every year for most of us. And so if a child has a diagnosis of 22q, how can a geneticist help? So as you can see from the list I gave you, it's a pretty complex disorder that requires a lot of coordination and making sure you're checking off everything on the checklist. And so it can help with coordinating ongoing care, because a geneticist will think about them holistically, whereas the ENT doctor is really good at ear, nose, and throat, the eye doctor is really good at eyes, but they may not think about other parts of the body that might be affected. We can give you advice on what to expect. So we can say, hey, other kids with 22q have trouble with this kind of learning or have problems with this part of their body, so watch out for that. We can help test other family members for the deletion. So that's an important thing to keep in mind. Sometimes people with 22q inherit the deletion from their parent. And parents sometimes have that deletion and are very minimally affected or not affected at all. And so I've certainly seen many families where a child gets diagnosed with 22q, and then we test the parents, and the parents think that they're perfectly healthy. They may have had a little bit of trouble in school, but nothing, over the top. It's not like they weren't able to graduate or weren't able to go to college, but then we find out that a parent had it. And so that can be very useful to know about for families, because that means their next child might have it. And that also helps explain perhaps some of the learning issues that the parent might have had or other things. So it's very important to see a geneticist to figure out if we need to test other family members. And we can also offer resources. And like I said, we'll talk about resources towards the very end. So now I'm going to move on to Williams syndrome, which is a condition that affects 1 in 7,500 to 1 in 10,000 people. So it's less common than 22q. It's a deletion of 7q11.23 seconded. And so I'll show you that on the next slide. And it has a combination of medical features. And again, this is not a comprehensive list because this is also a pretty complex syndrome. Children can have structural heart and vascular disease. So not only can their heart structure be abnormal, but their vessels throughout their body. They can have low muscle tone, so kind of lower strength in their muscles and loose joints. So a lot of the kids will walk late, sit up late, and things like that, just because they don't have that core strength that a lot of us have. They might have difficulty with growth and weight gain, so they might be small babies that just don't put on weight well. They can have mild intellectual disability, so almost every single kid with Williams syndrome has some degree of intellectual disability, and they can have lots of different hormonal abnormalities. So when do you suspect Williams syndrome? Quickly over here, this is chromosome 7. You can see that it's a lot bigger than chromosome 22. Here's the P arm, that's shorter. Here's the Q arm, that's longer. And right over here, 11.23, that's where the deletion would be for those folks. So if a child has specific types of heart disease called supravalvular aortic stenosis or peripheral pulmonic stenosis, you might think about Williams syndrome. I should say peripheral pulmonic stenosis can be fairly common in other healthy infants, so that alone wouldn't make you suspect it, but it's something to keep in mind. These children can have high calcium when they're infants. They can be born quite small, so something called IUGR or intrauterine growth restriction might be something they had, where they don't grow well as fetuses. They can have difficulty with weight gain, and they can be on the short side. They can have intellectual disability, like I said. And a lot of people with Williams syndrome have a very, very friendly personality. You know, everybody they meet, they want to be friends with, they want to talk to them, they want to hug them. I saw a little boy with Williams syndrome in the clinic recently, and he kept telling his mom the whole time that he wanted to come hug me, and he hugged me a bunch of times during the visit. So that's kind of the personality you see. And they can also have unique facial features. Like I said, you know, that's something that I'm trying to notice. Somebody on the street might not notice it though. So how do we manage Williams syndrome? We make sure that they're seeing a cardiologist regularly, not just when they're first born, but over time, because they can develop differences in their vessels over time. We make sure that they get their kidney and their bladder checked out with ultrasound because they can have differences in the structure there. We check their kidney function, so we do blood tests and urine tests. We check their calcium levels. We check their thyroid function with blood tests. We have them be seen by an eye doctor because, again, they can have differences in their eye structure and muscles. We check their hearing. And we do regular developmental assessments because, again, we expect them to have some difficulty with their development, and we want to stay on top of it so that we don't miss anything. So long-term care for Williams syndrome. Again, this is a pretty complex syndrome that has lifelong effects. Most genetic disorders have a lifelong effect, but Williams syndrome and 22q have a lot of medical issues as well, so that's why they have to be cared for long-term. We check their calcium really frequently until they're 2 years old. To check their thyroid yearly until age 2. We do their hearing yearly, we check their vision yearly, and some of the stuff we do for typical kids as well, but some of it's more detailed. We make sure we check their blood pressure in both of their arms yearly, and that's because of that vessel abnormalities that they can develop, as I mentioned. We check their urine yearly to check their kidney function, like I talked about. We make sure they see that cardiologist regularly. We do a kidney and a bladder ultrasound every 10 years because they can develop differences in their kidney structure and bladder structure over time. And as they get older, we check them for diabetes because that's something that they're more at risk for at a younger age. So again, how can a geneticist help? Just like with 22q, it's a complex condition that different specialists might think really strongly and well about their own organ system that they manage, but geneticists will think about everything that can go with Williams syndrome and can help make sure they're getting all the care they need. We can give you advice on what to expect. We can offer resources. And with Williams syndrome, you don't typically need to test other family members. It pretty much never comes from a parent, and I've certainly never seen it inherited because unlike 22q, where you can have the deletion and be minorly affected, if you have Williams syndrome, it's pretty obvious that you have Williams syndrome. It's not something that would be easily missed. So now moving on, we're going to talk about 16p11.2 deletion. So this is a condition that affects roughly 3 in 10,000 people. And it's a deletion of 16p11.2, which I'll show you on the next slide. And this has a combination of medical features, and most of them are neurological and to deal with learning and development and kind of psychiatric things. So these kids can have developmental delay. They can also have intellectual disability. They can have autism spectrum disorder. They can have obesity and a large head size, and they can also be prone to seizures. And so when do we suspect 16p11.2 deletion? So just showing you here, this is chromosome 16, P arm, Q arm. Oh, I put this on the wrong side. I'm sorry, that's my fault. So this little X should be up here with 11.2 on the P arm, on the short arm. That was my bad, I apologize. But they would have a deletion there. Now, when we suspect it is when a child has developmental or a learning disability or autism spectrum disorder, especially when it's combined with obesity and a large head size. So how do we manage this deletion? So like I said, most of the features are kind of neurological and developmental, so we focus a lot on that. So we support their development with therapy, support their learning with an individualized education plan or IEP. You may have heard about that if you have kids who need special help in school. We check their hearing because they can have some hearing loss. We do spine x-rays because they can have some differences in their spine structure. We do that at diagnosis and yearly. We watch them for seizures. So if we diagnose a child with something like 16p11.2 or something else where they have a risk for seizures, we don't, immediately send them to the neurologist or immediately medication, but we tell the family, watch out for these kinds of things so that if it happens, you can quickly get them seen. We try to manage and maintain a healthy diet to reduce the health effects from obesity. Now, not all children with 16p11.2 will have obesity, but they are at risk for it. And then we do regular developmental assessments, just like with all the other syndromes we talked about. And I didn't mention long-term care here because most of it is with the learning and the development, and there's not severe health effects later on in life in terms of physical health. So again, how does the geneticist help? Helping with coordinating ongoing care, just like all the other syndromes, giving advice on what to expect, offering resources, and in this case, we do want to test other family members because there are people who can have 16p11.2 deletion and have no symptoms at all or have minor symptoms. And so there's certainly a possibility that you can inherit it from a parent who doesn't realize they have it. Now we're going to change gears and talk about 16p11.2 duplication. Similar to 11.2 deletion, it affects roughly 3 in 10,000 people. And I should say for both the duplication and the deletion of 16p11.2, we think there's probably people walking around who don't realize they have it, partly because they can have no symptoms or they can have minor symptoms. And so this number of 3 in 10,000 might actually be higher than what we expect. It has a combination of different medical features: developmental delay, ADHD and autism, intellectual disability. They can have mental illness later in life, so anxiety, depression, schizophrenia. They can have a small head size, low weight and trouble gaining weight, and other birth defects, quote unquote, so differences in their heart structure, kidney structure, and so on. None of those birth defects are super common enough to list them here, but they can have them. And so similar to the deletion, this is a syndrome where you have mostly neurological issues, but interestingly, where the deletion, people tend to be a little bit on the larger side. In the duplication, it's the opposite. This doesn't always go for deletion and duplication of the same region, but for some of them it does. So again, I did this the wrong way. I showed 16q11.2 duplication, and I apologize for that. It would be p11.2. So I think we might put these slides online. If we do, I'll make sure to fix this before we do. So what to suspect 16p11.2 duplication? So any child who has developmental delay, especially significant speech delay, if they have autism, and especially if that's combined with low weight or small head size. How do we manage the duplication? Just like with the deletion, we really support the development with their therapy, support their learning with an IEP. We perform kidney ultrasounds because they can have heart structures and differences in their kidneys, and that's one of the more common birth defects. We support their growth with a healthy diet, but we also recognize that because of their syndrome, they tend to be smaller. So it's not like we have to push them to gain weight. And we also do regular developmental assessments, just like we would with every other child. Genetics helps in pretty much the same way. And just like with the deletion, people with 16p11.2 duplication can have it and have no symptoms. So we want to test other family members to see if it could be running through the family. And so one thing I forgot to put in a slide here is actually, you may be wondering, my child has developmental delay, my child has this or that. Do I have to ask somebody to test them for a specific syndrome, or how does that work? Almost any child who has developmental delay, autism, and things like that, they should get referred to a genetics doctor, or somebody should be sending a chromosomal microarray on them, because that's a test that's recommended by, American Academy of Pediatrics, American College of Medical Genetics. Most of the professional societies will say if a child has any problems with development, they should get a CMA, because they could be at risk for some of these syndromes as well as many of the other ones that we didn't talk about. And so that's a pretty standard test. And if you do have a child who has developmental delay who hasn't had one of those tests or that CMA, I would encourage you to ask your physicians about that. So I'll wrap up quickly with just a few of the resources, and I think we'll probably be able to make these available either in the chat box or later on. So Medline Plus Genetics is a great resource for all types of different genetic disorders, not just CNVs. And so if you say, my child was diagnosed with, Fraser syndrome or something like that, you could Google that with Medline. You should be able to find a little family-friendly explanation sheet about it. Genetic and Rare Diseases Information Center is also a place where you can find information. And sometimes if you don't find stuff on Medline Plus, you can find it on GARD. Unique is a wonderful website that I'll show you a little bit more about next slide that has disorder guides for a lot of the CNVs and some of the single gene disorders as well. So if you have a new diagnosis of it, or if you're trying to learn more about a particular diagnosis, you can go there and download their free guide so that they can learn more about it. And it's all written from the perspective of families and patients. And so you really get the sense of what it's like to live and care for that patient, as opposed to, or for that child really, as opposed to seeing it from a doctor's perspective. Now, speaking of a doctor's perspective, Gene Reviews is a great resource for that, and doctors can learn a lot there. So if you have a child who's diagnosed with a specific syndrome and their pediatrician isn't too sure where to get information, you can suggest Gene Reviews to them. And so Unique, like I talked about, has free disorder guides. If you go to rarechromo.org, or if you even Google Unique disorder guide, you'd probably be able to find it. And you should be able to find this on their slides, on their website. And so support groups for these particular syndromes, we've listed them out here. And I think we could probably make them available in the chat box as well, if y'all wanted to learn about these specific syndromes.
Well, hi, you guys. Thanks for joining us on a Saturday morning. We're really happy to have you here. I had a little bit of a dicey morning with my internet service, but it seems to have cleared up. So fingers crossed. I'll tell you a funny story. I have a reputation because twice I've been teaching online, and a squirrel has gotten on my power line outside and run into the transformer, and there's this loud explosion, and then everything's gone, including me. So I'm hoping no squirrels are out this morning. So I do work for the University of Texas at Austin at what we call a UCED, a University Center of Excellence in Developmental Disability. It's a mouthful. It's federally funded. Every state in the country has a UCED. We're a really big state, so we are lucky to have two UCEDs, one at Texas A&M and one at University of Texas at Austin, and I'm happy to say we collaborate. And I am a former special educator and a licensed counselor, but my most important letters are those last three. I am a mom. I'm a parent of a 32 in July, 31-year-old young man with a genetic condition that I'd certainly never heard of before he was diagnosed at the age of 3 months. And so I've spent 31 years figuring out learning how to live with what can be a scary diagnosis sometimes. And that's what I want to share with you today. Because after you leave the geneticist's office with the information that you might have just received, some of which might have been completely unexpected and overwhelming, you still have to go home and live a life. So that's what I'm here about today. And I want to share work with you from a group that I'm a part of called the Learning Community for Person-Centered Practices. So it's not my personal brilliance I'm sharing with you. This comes from the work of a fabulous bunch of people all over the country, as well as in Canada, Great Britain, Australia, most recently in Africa, and I think India, but don't quote me on that. Anyway, and it's all about helping people have positive control over the lives that they want for themselves, regardless of the disability. And positive control, we're talking about being able to say with your words or your behavior what works for you, rather than what we know often happens with kids or young adults, even adults with disabilities, where they've not been given a lot of power and they exert their power through behavior that people find challenging. We don't want people to have to resort to that. We're about helping people get better lives, not just better paper. And if you spend any time in the disability service world, either as a professional or as a family member, you know that a lot of paper gets created around our kids, and not all of it makes a difference. We want to help you make paper that makes a difference. So here's the core concept. If you get nothing more than this, we will consider it a win. It's called the difference between important to, important for, and the balance between them. They sound like the same thing, but they're very different. So let me explain. Important to is anything in a person's life, and I'm applying this to kids with specifically some kind of deletion syndrome or different syndrome today, but we apply this to people in general. This works for me, it works for you. It has been used in prison populations with people who are living with homelessness, people who are dealing with end of life planning. This doesn't matter about disability. This is about people. I'm applying it to the conditions that we discussed today, but it works for all of us. It's anything that helps us feel satisfied, content, comforted, fulfilled, or happy. And if you think about that, there's a lot of things in your day. And, I think many of us have become newly aware of some of what's important to us in our lives because of the COVID pandemic. All of us have lost some things that were important to us. We've lost places that we went. You'll see places to go on this list. We've lost people we like to be with and the relationships we shared with them. We may have lost some of our purpose or meaning. I traveled for work prior to the pandemic, and I'm still doing the work that I did, which gives me great purpose and meaning, but I lost the meaning that I gained when I got to go and sit down with family members at an event like what we're doing today. I miss that. All of us have lost some of that. We've lost some of our rituals and routines. Many of us are working from home, which is not the ritual or routine that we had pre-pandemic. And it's even about our rhythm or pace of life, which I think has also been interrupted by the pandemic. So I think all of us can kind of relate to this. But if you think about our kids or children, young adults with the syndromes that our doctor talked to us about today, how much of what they have lost about what's important to them has been lost because of the diagnosis, because of the medical conditions. And that doesn't happen intentionally, it happens accidentally. I'll show you why in just a moment. But if you're wondering what's important too, just ask yourself, is this something that helps my child or helps this person feel satisfied, content, comforted, fulfilled, or happy? If it answers any one of those emotions for this person, it's important too. Also important too includes what that person defines as quality of life. And I think, again, COVID has raised this issue to a greater level of awareness in our world, because we talk about quality of life like we all know what it means. But all of a sudden, do you define quality of life as being in the hospital on a ventilator and unable to be with your family? Some people say no. So how does this person define quality of life? And the last thing that we have on this slide is reminding us that people can say what's important to them with their words, but they're also saying it with their behavior. All of us do. And some people don't have words that they say verbally, and we have to rely on their behavior. But if behavior says one thing and words say another, maybe you've seen that before. Maybe your loved one says, I've got to lose 10 pounds. I'm just going to have to lose 10 pounds. But they're eating all the junk that they ate yesterday and the day before, and they said they're not interested in the gym. They're saying with their words, losing 10 pounds is important to them, but their behavior says something different, right? When we're dealing with somebody with a label like we talked about today, when there's a difference between words and behavior, always go with behavior, because actions speak louder than words. But then ask yourself why. Because many people, and I can say this about my own family, my son included, as hard as I've worked to empower him to speak for himself, they get really good at thinking they know what we want to hear and saying what they think we want to hear, regardless of what they're thinking in their heart. So always pay attention to the words and behavior, but ask yourself, why is this person saying what they think I want to hear? And we often completely miss important too, because when there's a medical diagnosis, especially one that requires a lot of attention, we get laser focused on important four, which is basically talking about health and safety. It's making sure this person takes medicine when they're supposed to, that they get the treatment they're supposed to medically, that we promote good health and wellness. We keep them safe. We don't want to take any unnecessary risk where they could get hurt. And unfortunately, for people with medical conditions and or disability, often we're so laser focused on important four that we don't let them take any risk. And there is dignity in risk. We learn a lot from taking risks and making mistakes, but we protect people from that, and unfortunately, we do them a disservice. There's another part of important four that I'll share with you, and that's what you see as needed to help your loved one be seen as a valued, important person in their community, somebody who contributes. And so we want to pay attention to those things as well. And it can be as simple as how we're dressed when we're with them, how they're dressed when we're with them, how we treat them when we're in the medical office. Do we do all their talking for them? Or do we ask the medical professionals to ask him, ask her? You know, we encourage empowerment. That's a way to help our loved one be seen as a contributing member. And then know that these two are connected. They influence each other. And nobody, not any of us on this call, not any child we work with, not any child in my life who are young adults, nobody does what's important for health and safety without some piece of it being connected to important too. And I'll show you an example here in a moment. And know that the balance is dynamic. It's always changing. When, you know, if we're laser focused on important for and we put all the balance on important for, it's out of balance. But a parent's worst nightmare is where the kid gets everything that they want, important too, and we're not paying any attention to health and safety. That doesn't work either. We have to balance. So it's your turn. I'm going to let you try this out. We'll use the chat box. Susan, I'll let you monitor that for me. I want to introduce you to my two dogs, Coda and Willow. Coda is the border collie on the left, and Willow is the golden retriever on the right. And they know that I have something in my hand for them. They have to have a heartworm pill every month to keep them from getting heartworms, which would kill them if you don't know anything about dogs and heartworms. And so let's do an important 2-4 sort. Heartworm pill. Is that important 2 or important 4? Put it in the chat. Important 2 or important 4? What do you see, Susan? You're muted, Susan.
Seeing important 4.
Oh, excellent. Excellent. You did a great job on that. Okay. Well, so Willow, you can see she's very excited about this heartworm pill. She'll take it in a heartbeat. It says on the box it's flavored like a treat. She buys that. Coda, he knows it's not a treat. So let's do another important 2-4 sort. Peanut butter. Important 2 or important 4? What do you think? Do it in the chat. What are you seeing, Susan?
2, 2, 2. Important 2.
Oh, excellent, y'all. Excellent. Well done. Peanut butter is important too. But let me ask you this, and this is what we do to people with disabilities all the time. How do you think it would work if I said, Coda, you can have this peanut butter after you eat this heartworm pill? Is that going to work? It's not going to work. I'll find the heartworm pill behind the couch. He will peel the peanut butter off and dump the pill. I have to take the heartworm pill, important 4, and encase it, wrap it up in a ball of peanut butter, important 2. And that's what we have to do for people we are supporting. We have to take what's important for them, their health and safety, their medical health and safety, their dignity of risk, and wrap it up in the context of something that's important to them. And they'll do it every time if it's truly important to them. We have to support the person to be healthy and safe within the framework of what's important to them. So I want to show you, as we finish up, I want to show you what we call a one-page profile. And I have to do this quickly, but Susan will share the handout with you, and it'll give you the information that I've shared with you today. A one-page profile, what is it? Why should we? It's a way of informing whoever your audience is about who your kid or who this person is in terms of important to and how they're best supported. So here's a blank template. This is in the handout that Susan will share with you. I'll show you some much more interesting, inviting templates at the end. But basically, you want to put a flattering photo of the person, not the mugshot that often shows up in like school IEP folders or medical folders. And then you want to put what's important to them in this setting. We always want to put what people like and admire about this person, because a lot of our family members have files that are this deep, and it's all about who they are not, what they'll never be, what they never can do, what's wrong with them, how bad it is. Nobody wants to be talked about that way. So we start out by talking about what people like and admire about this person. And then most important, the green box on the bottom, how can this person best be supported? Here's my son. This is his medical one-page profile. You see, I took a picture of him in his truck behind the wheel. I want medical professionals to know he drives. That's important. I don't have to tell them. They can see the picture. The sentences in white font are specific to medical settings. So doctors get a sense of, or whoever, we're working with, get a sense of who he is in spite of his medical condition. He wants to be respected. He knows when you don't think he's competent. Help him understand what you want him to do. You might have to show him. Ask his permission before looking at his facial or head tumors, or asking him questions about his disease. He has a long history of doctors walking into the room who have no business there other than they want to meet somebody with his disease, his diagnosis. And he's figured that out. Help me manage my medications and diet. Explain what they're doing and why they need them. Don't just prescribe. So this is some really important information, including, like the next to the last one, tell me what you're going to do before you do it and give me choices about how it's done. For example, if he has to have surgery, he would much rather have a needle than any bad tasting medicine or a gas mask. The gas mask is just scary as all get out because of the smell. He's super sensitive to smell. And then use a fun sense of humor with me. That's an example of a one-page profile. And great things on the top right. I wanted medical professionals to know who he is outside of his condition. So we don't put anything there about functioning level or problems. We put who he is. Here's another medical one-page profile. This kid has Chard syndrome. He's blind and he's deaf. And his mother wrote this for 2 new doctors that we're going to go see. The first doctor, she emailed it. It landed in his junk box. He didn't see it. It was a disaster, the first appointment. But the second doctor got it. She printed it out, showed it to everybody in the office, including the ladies at the front desk. And everybody knew how to work with Liam, knew how to make him feel comfortable, including he's blind. He needs an identifier, like maybe it's the ring on your finger or it's the necklace around your neck or your earring, that he can know who you are when he meets you. They knew how to do all of that because of this one-page profile. Now, to the first doctor's credit, he discovered it in the junk box and wrote the mother an apology and invited them back. But this is an example of what a difference a one-page profile can make if it's well done. And I'll talk about that here in a moment. Here's one more. This is a good friend of mine, Sophie. Sophie has some pretty unique genetic differences, including an inability to use words. And you can see some really important support information, as well as what's important too. For example, the first sentence in important too for Sophie is always having access to her treasured bag of photos of friends and family. She carries them everywhere she goes. Now, if you go down to the best support, you'll see that she uses her treasured photos in her iBed to help distract and get calm. So that tells the medical professional how that bag of photos can be helpful to them as well as to Sophie. And even some important information like, be willing to let the height and weight information go. So getting Sophie on a scale is not easy. And she sees a lot of medical professionals, and mom is very diligent. Just get that information from mom, as well as blood pressure and stethoscope. She may not tolerate that day. Be willing to let it go. We'll get it another time. Important information. So let me tell you how to do this very quickly. You want to ask yourself these questions. Where is this one-page profile going to be used? Because context is key. The biggest mistake I see being made with one-page profiles is where people see some examples like the ones I've just shown you and they go, oh, that's a great idea. I can do that. And they go create what I call cute one-page scrapbook pages. They have lots of cute pictures and lots of cute, interesting information, but it's not specific to a specific place or situation, and therefore it's not helpful in that setting. So ask yourself, what's the context here? And then what do I want the readers to learn? So your context would be, say it's a first medical appointment, or it might be an annual appointment, or it might be a geneticist appointment. Where's the context? Where's it going to be used? And what do you want the readers to learn in that context? And then last and most importantly is, how is support best provided in that context? How can you support my child at this first medical appointment or at this geneticist evaluation, whatever? So the context for this talk today would be healthcare settings. I always start with like and admire. What do you love about this person outside of medical conditions and diagnoses? Stay away from that stuff. They've already got that in the file. Stay away from functioning levels. Focus on the personality, gifts, and abilities. And then what's most important to this person at medical appointments or healthcare settings? And then lastly, how is this person best supported in that context? And I gave you some questions to prompt your thinking, and this is in the handout, to prompt your thinking about how my loved one or the person I'm supporting could best be supported in this setting. For example, how does this person express pain? How is that best alleviated? What causes anxiety and what helps ease it? Or fear or discomfort? How does this person communicate? What supports are helpful, etc. And so I'll close here. I'll put my information up. If there's a question or comment that I didn't have time to answer today, you have access to my email. I'd be happy to try to answer your question later if I can't today. And I'll turn it back to you, Susan. Thanks.
Oh, thank you, Laura. And thank you, Dr. Murali. These have been really interesting and fantastic presentations. So I'd love to open it up for questions. We have really one more minute, but you're welcome to put your question in the chat or raise your hand and we will look at the, and see if there would be a hand up, either virtual or your real hand, however you'd like to do that. But I think this has been, there is a question here from Nina Zuna. Do errors occur in the results of a CMA, missing a genetic disorder or saying there is a genetic abnormality when there is none?
So that's a good question. I would say that it's unusual. Sometimes CMAs, as with any testing technology, as with any genetic technology, it gets better over time. So if your child had a CMA 10, 15, 20 years ago, well, probably not that long, but 15 years ago, it would not have had as high of resolution is the term we use. So it's not as quite microscopic as the ones today. So an old one may not have picked up a very small deletion or duplication that a new one might. So that's a possibility. In terms of saying there's a genetic abnormality when there is none, I haven't often heard of them picking up a deletion or a duplication that doesn't actually exist. But sometimes, like I said, we learn more things about genetics over time. So they may call something pathogenic or VUS, which means definitely disease causing or maybe disease causing. That we later learn is not so much as we learn more about the syndrome, as we learn more about the people with it. So that's a possibility. But the main thing I think to keep in mind is that a CMA done 10, 15 years ago may not have been as good and microscopically as the ones done recently.
Thank you. We are at the hour, so I really thank you, Dr. Murali. Thank you, Laura Buckner. And thank you all for participating this morning on a Saturday morning. This is fantastic information. We will have this webinar available on the website, and I will let you all know when they're available. We'll send out the handouts. I did include a link for the surveys. I really ask that you complete the surveys because this will help us tremendously in the future in planning these and also giving feedback to us in our program. So we do have 2 additional Saturday webinars coming up. On Saturday, April 10th, our webinar will be in Spanish, and it will be on the topic of indicators for a genetic referral for families that may be trying to figure out if their child does need an evaluation. And that one will be presented by Dr. Lizbeth Mayin and Ms. Laura Buckner. And then on Saturday, April 24th, our topic will be Fragile X syndrome, a conversation with Dr. Daryl Scott and Ms. Laura Buckner. So we really thank the speakers and thank you all for being here this morning. And we will say goodbye and have a great rest of your day. Thank you.
Thank y'all.
Bye, everyone.
Bye-bye.
Thank you.
Bye-bye.